I'm Vic Koivamaki, member of the Reunion Committee and the convener of this panel. I'm not going to do anything by way of introductions. You've got their CVs. I think what we want to do is hear from our distinguished classmates who are experts in this field of healthcare. So what the format is this: they're going to each speak for 10, no more than 15. I'll sort of, give them the cutthroat at the right time. And they're all going to do their piece, handing off to each other. And at the conclusion, we'll have questions, although if panelists want to quiz each other during their presentations, that will be the way we'll do it. So we've got Don Berwick, Peggy Kemeny, Jim Roosevelt, Christine Bishop, and Hal Luft. And so we've got an East Coast, West Coast start to finish here. And with that, they'll do their own introductions or whatever they want to say, although I said you don't go through your whole CV because we've all got it. And first, we'll start off with Don.
Thanks, Vic. It's a real thrill to be here, and can't wait to more interactions and catch up with all of you. I think I won't go over my CV. You can read it in the reunion book and whatever. Ask me questions later. What I'm going to try to do is tee up the panel with a read on where things are now in the healthcare reform and policy world as quickly as I possibly can do it, and then we've got some real experts here to help us dissect it a bit more. And then I think one of the purposes here is to try to translate it into what it means for us as individuals, which is a neat undertaking. But I'm going to take the kind of the 30,000-foot view. I need to begin with a metaphor. I've been using this in speeches this year. This is a bridge in Honduras. It's the Choluteca River Bridge, which is near Tegucigalpa, I gather. It was built in 1938 by an American company, the American Bridge Company, which built the Bronx-Whitestone Bridge, very famous, very strong bridge. It was really built well, which it has to be because the weather in Honduras is terrible, I gather. The worst episode was in 1995 when the bridge was subjected to real tests by Hurricane Mitch, which hit Honduras head on. It took down 150 bridges, killed a lot of people. That's Tegucigalpa. It's a picture of the capital city in ruins. The bridge did not fall, though. The Choluteca River Bridge stood proud. The only problem was the river moved. So apparently, I haven't been to Honduras, but if you visit, this is American healthcare. It's an unfair, cheap shot. I mean, the first bridge, the one we have, that's technocratic, hospital-based, audacious, biotechnically very skilled, and miraculous in what it can do. When I trained in peds, every kid I saw with acute lymphoblastic leukemia died. They all died. Some of them in my arms. And today they all live if we don't make a bad mistake in their care. They don't have a complication. We can transport organs. We can do things that I wouldn't have dreamed about when I was in training, and that was, just a few years ago, right? So nothing I'm going to tell you is about disassembling or removing Bridge 1. We need it, and we want miracles. The problem is that doesn't help most of us, and most of us are in the other river, or headed there, and that is chronic illness, the journeys we're going to make through life with borderline congestive heart failure, with our diabetes, it's depression or violence in society, it's the upstream causes of all of that, nutrition problems, problems of environmental threats. I think it's the river of end-of-life care, where we have not built in this country yet the infrastructure we need for advanced illness. And you can fill in the blank, but there's a massive need in this country for care that's continuous over time and space, that's dignified, controlled by the people who get the care, and effective in its use of resources, not wasteful, and that bridge is not built. This is an amazing country. We can get to the moon, we can clean the air, we can build the interstate highway system, have a Marshall Plan, we can do all that kind of big stuff. We could move the bridge or build the other bridge. That's not out of our reach. I'll show you how to do it in a minute. The problem is that we're not, and the barriers are severe. I'll show you some of them later, but the biggest problems we have are not just the technical problem of creating the new care system we need. It's two other big problems. The first one is the economy, which we have to reinvent American healthcare at a time of enormous stress on the total economy, with a particular important nuance, which is the stress is caused by healthcare. So if you look, as I am now looking at the state budget, Massachusetts state budget, every line item in our state budget in 10 years has gone down. Local aid's down 45%, higher education's down 30%, parks and recreation 25% down. Every line item's down except one, that's healthcare, and the state cost of healthcare for the state government is up 59%. And if you go to the private sector, you'll hear the same thing. I didn't know this until I was running Medicare, but the real wages in this country, there's been no increase in take-home wages for laborers in America in 10 years. None, zero. All of the increase hasn't gone to the companies they work for or to the laborers, it's gone to healthcare. It's just taking everything. Because that first bridge is very expensive, and not meeting the second kind of need adds to the cost instead of decreasing costs. It's a massive problem. It's only one of two. The other massive problem is political disaster. I mean, we are in a country where civility, it seems to have disappeared. People don't sit down and work through problems. I saw that firsthand when I was working in DC. It's pretty dreadful. The public's losing trust in the ability to solve large problems. So now you propose a moonshot, or whatever the right metaphor is, build a new bridge, and you don't get a public that's kind of ready for it and up for it. They don't believe that they're being told the truth. They think it's a trick. There's a way out, and it's the one that I devoted my career to for 30 years, and that's improvement. Things get better. Computers get better all the time because there's a systematic way to make them better. And if we can buy a computer today with much more function at much lower cost. The general idea that making things right and better lowers cost is quite true. The Institute for Healthcare Improvement put out, that's the organization I ran for 22 years, put out this about 10 years ago and said what we need in the social sphere, so what society needs from healthcare is three things. We call it the triple aim. Better care, so let's treat the heart attack correctly. Let's make sure that people get control over the care that serves them. Let's not have waiting times. Let's coordinate care. Better health, so you don't have your heart attack in the first place. Let's get serious about obesity and diabetes and nutrition and justice and equity and poverty in the society. You need less care. And the third is reduce the per capita cost so that laborers can take it home in their paychecks, or governments can use it for the safety net, or industry can use it for global competitiveness. Better care, better health, lower cost. That's my theme. We have the Affordable Care Act. You may want to ask questions about Obamacare at some point during this 2 hours. I'm happy to help address them. But we do have a new statutory structure in the country, which is pregnant with possibilities. It's doing two things. It's trying to provide coverage. It's trying to make healthcare a human right in this country, which it is not yet, but should be. It's moving in that direction, and it's trying to move the bridge, build the other bridge so that that becomes sustainable. That's the statutory context, which we happen to be in right now, kind of historically so, which gives us a chance to actually do quite a bit of new and important construction of care. Is it possible? Could you have better care, better health, and lower cost at the same time? Since I've spent my career devoted to that pursuit, I know the answer. It's yes, and I'll show you a few examples of what it looks like, because this is the challenge of the new bridge. It's what it looks like. The best example I know right now that I've been talking about for a year is NUCA. It's in Alaska. It's in Anchorage, Alaska. It's the native-run, native-owned care system for the Alaska Natives in the Anchorage Bowl, 60,000 people. I worked there because my wife, Ann Greenberg Berwick, your classmate, she got a sabbatical year in Anchorage, and we moved the family there in mid-1990s, so I know this system very well. Starting in 2004, that system, South Central Foundation, that's the corporate native structure, set up this primary care-based, home-based, prevention-oriented second bridge system, I guess I'd call it. It's all about keeping you well. The last thing they want is to put you in a hospital. If you can do something at your home, they want it there. It's spiritually oriented. They use native healers. It's an amazing system. And just to show you the bottom line, this is what they've done in 5 years in NUCA. They've reduced urgent care visits 50%. They've reduced hospital bed days 53%. They've reduced specialty care 65%. Primary care down 20%, and they have the best quality scores and the best satisfaction of patients and families, and interestingly staff, that they've ever had, that anyone's had. It's an amazing system. Better care, better health, lower cost. Here's another example. This is a telemedicine example. This guy here, Dr. Aurora, Sanjeev Aurora, he's at the University of New Mexico. He's a liver specialist. He knows how to cure hepatitis C, which is very difficult to do. It's a very bad infection, but it can be cured with delicate use of drugs. Before he took over, you had to go to the medical center to get to this university center, no matter where you lived in New Mexico, to get your hepatitis C cured. Not now. He set up a telemedicine system. It reaches knowledge and instruction and coaching into all the primary care units all over the state of New Mexico. including units with just nurses, not even doctors. And he's getting better results with a distributed system of knowledge use in local settings with patients that never ever have to go to the university center. He's getting better viral eradication for hepatitis C than they get in the university center. This is a wonderful project I saw in Alaska. This is the Dental Health Aid Therapist Program. I used to see kids in little Eskimo villages in the Bering Sea coast when I lived there, and when I lived in Anchorage. I would fly out to these little villages, like Scammon Bay. How do you get a dentist to Scammon Bay? You can't get a dentist to Scammon Bay. There's not enough dentists. What you can do is train a high school graduate or a junior college graduate in a program supervised by 3 universities to use this thing here. That's a dental workstation. He gets on the bush plane, flies to Scammon Bay with this little box, opens it up, and does complete dental care. He can fill caries, he can do dental prophylaxis, simple restorations. They're going to meet all of the needs of rural Alaska dental care with 70 DHAT therapists. They don't need the dentist. These are breakthroughs, they're innovations. They make care better and cost fall at the same time. How much could cost fall? How expensive is that second bridge? Let me show you. I published a study in JAMA, Journal of the American Medical Association, last year with my colleague Andy Hackbarth at RAND. We just did an assessment of 6 kinds of waste, the way we spend $2.7 trillion in ways that don't help anybody at all. We analyzed overtreatment, that's doing too much for people, giving them tests and treatments they just don't need, and I can give you a whole bunch of examples. Failure to coordinate, that's not being NUCA. Failures in delivery, that's just not being reliable and following science. Excess administrative costs, that's hassling doctors and nurses and managers. Excess pricing, which is a competitiveness failure, but we don't have commodity pricing in healthcare. You don't get commodity pricing because you don't have things competing with each other, even though they are commodities. And then fraud. If you add up the lowest estimates in the entire literature, you get to 21% of the bill. You add up the highest estimates, that's 47% of the bill, and the median was 34%, and that's the same number, 30%, that was arrived at by the Institute of Medicine 6 months later in a completely different study. 1 out of $3 in American healthcare is going into absolutely pure waste. That's because we're trying to use Bridge 1, the technocratic miracle bridge, to solve the problems of the river, and it isn't going to work. You can't do that. Better care, better health, and lower cost is not just a mantra, it's a solution. It's the way out of the mess. The other solution is to take things away from people, ration care. We could do that. We'd be less ambitious. We could say you can't have this care because we can't afford it. I don't think that is absolutely necessary at the slightest bit in this country if we could get things right. Thanks, Vic. So why don't we go there? Why don't we just go from where we are to this wonderful future state, better care, better health, lower cost? This is the problem, the first bridge. We built a legacy system, intensive in capital, with a labor market that's fit for miracles, but not for continuity, not for the kind of care we really want to give. And drilling through that's really hard. You have to imagine a healthcare economy in this country, like NUCA, where a hospital CEO celebrates and is rewarded for empty beds. That's how dramatic this change is. Today, someone that flies to NUCA comes back to a Boston area hospital and says, I have a way to reduce our admissions 53%, will not have a long conversation because the system's set up wrong. We can do it. These are the principles that I think need to they're actually the guiding principles to me. The first is put the patient first. If we actually oriented the care around the need, we wouldn't have to hurt anybody at all and we would solve the problem. The problem is we're not meeting the need. That's the cost problem. The second is the moral test of making sure the poor get it first. Illness and poverty go together. If we don't commit to social justice, including in the way we give care, we're flunking as a country. And so the solutions have to put the poor first. That's my opinion. The third is it's game time. The idea we'll pilot our way into this, little tests will solve it. No, it's not going to work now. There's a horse race on, and the forces of rescission, the forces of take it away, they're winning right now. They will win if we don't get the change started fast, at scale. The money's got to get back to the workers. It isn't good enough for healthcare to save the dollars. Healthcare has to return the dollars through the premiums that people pay, going right back into the pockets of the laborers. The only source of money for healthcare in America, the only source, is the wages of labor. There's no other place that healthcare money comes from. Think about it, whether it goes in taxes or out of pocket or insurance. And then the last, I think, and the most exciting is it is possible to do this locally. I'm absolutely sure that communities and towns and cities and collectives could pull this off. They can build the second bridge if they really want to and need to, and we badly need the examples. Now my colleague panelists are going to tell us how to do that. Let me introduce Peggy Kennedy.
So I'm not exactly sticking to the topic. I'm going to talk about something that I know a lot about, and it's kind of on the topic. So this is a quote from Martin Luther King. Of all the forms of inequality, injustice in healthcare is the most shocking and inhumane. I mean, the Obama administration should be showing this every day to everybody, but that's life. So I work in a city hospital, not in Alaska, but in New York City, in one of the boroughs, Queens, and we're 92% minorities patients in that hospital. So this is about the ethnicity variation in cancer burden. And if you look at I put the pink arrows in for the African Americans, that in prostate cancer, lung cancer, breast cancer, and colon cancer, the African Americans have the highest mortality. So, everybody at the NIH is scratching their heads. Why do the African Americans have the highest mortality? Well, I mean, they can ask me and I could tell them. So let me talk about Queens, where I work. So Queens is a really unusual place. It's the second largest borough in New York City, has 2.3 million people, and as a standalone, it's the 5th largest city in the United States. There's over 20,000 residents per square mile. 67% of the population are minority groups. And I was telling someone in my hospital, 108 different languages are spoken by the patients. It's the fastest growing county in New York State. They have almost 500,000 African Americans in Queens, which would make it the 11th largest county of African Americans in the whole United States. And 1 out of 6 residents lives in poverty. Cancer is a big problem in Queens, like it is in all the other parts of the United States. And the majority of cases are lung, colorectal, breast, and prostate. And there's a lower rate of early detection in the rest of the United States. So here's the problem. So I think, as you all know, late detection of breast cancer, of any kind of cancer, usually means we're not going to cure it. We want to find people at earlier stages so we can cure it. So if you can see here that for breast cancer, look at breast cancer. So in Queens Hospital, which is the public hospital that I work in, when we started the cancer center in 2002, a third of the patients who came in with breast cancer had late-stage breast cancer. In the rest of the United States, only 12%. So it's 3 times as bad as the rest of the country. Same thing, in every kind of cancer, was much worse. Colon cancer, 40% versus 38%. So this is the problem. The people are not getting the care they need, and they're not getting there soon enough. And that's why they're dying from these diseases. So what we did is start a comprehensive cancer center. Now, sadly enough, this is the only comprehensive cancer center within the public hospital system of New York City, the biggest city in the United States. I mean, why this is true, I don't know, because the way to treat cancer, the best way to treat cancer is in a comprehensive cancer center where you have all of the modalities at one place. So what we did was we built a state-of-the-art comprehensive cancer center. We established a clinical research unit, which is very important for these patients because otherwise they can't get access to new drugs and new modalities of doing things. Memorial Sloan Kettering will not take these patients. They get a lot of money from the United States, from the NIH, but they do not take patients who do not have insurance. And we knew that we had to affect ties with the community to educate people on cancer. We created a survivors clinic, which is kind of a new way of treating cancer patients that we're going to have to do in the future because there's going to be more and more cancer patients alive who have survived cancer and how to take care of them. And we had to, of course, bring early detection strategies to the community. So one of the things that we started doing there, for instance, was we decided we had to have a PET scan. Every cancer center that's called a comprehensive cancer center has a PET scan, a PET CT scanner. There was no PET CT scanner in the public hospital system of New York City. So we organized a fundraiser and got the people from the city council in. We got some of the people from the state assembly in, and we got these people to stand up and say they were going to donate the $3 million to build the PET scanner, and they did. So now we have a PET scanner, and we're the only ones in the public hospital system in New York City. And then we had different strategies. We had an anti-smoking campaign. We got money from New York State to give us money to start a smoking cessation campaign. We did a lot of breast cancer training, teaching people. We use the public library system to try to get more people to do mammography, decrease prostate cancer with early detection campaigns using PSA. And I just make an aside note, I think a lot of you saw in the papers that now they're wondering whether people should use PSA test for men. For African American men, there's no question they should use it. They get it earlier, they have more of it, and they die more from it. They should not stop PSA testing in African American men, and yet they're talking about like they're supposed to do it for everybody. This is wrong, and should be straightened out. And obviously a campaign for more colonoscopy in these people. So we also got onto these prevention trials that were available at that time. And again, the wrongheadedness of the NIH, I have to say. So the National Cancer Prevention Trial was a trial to look at whether giving tamoxifen to women who are high-risk breast cancer, but didn't have breast cancer, just normal women, but were high risk, usually, the parents had cancer, various other factors, whether giving that to them versus a placebo would help. So they underrepresented the African Americans in that trial. Instead of keeping the trial open for African Americans, because it's harder for African American women to be in that trial because the model they used was against African Americans, but at any rate, there were less of them in that trial. And so when the trial finished, there were 13,000 women in that trial, only 2% were African Americans, and they couldn't answer the question for the African Americans. So for the white women, in case you all don't know, it is, if you're high risk, tamoxifen is recommended. But for the African American women, they couldn't say that. That was a real mistake on the part of the NIH. They should have been able to answer that question for that group of people. So we did this very, very interesting study with the NIH where we used the Queens Library system to try to get to the patients. You have to figure out a way to get to the community. And like in Queens, they have the largest library system in the country. So they have 63 public libraries throughout Queens, and they say that a person can walk, everybody in Queens can walk to a public library. And so we did breast cancer training, colon cancer training in this public library systems, made these little groups, they're called Cancer Action Councils, so that they're people from the community that are around the libraries and try to get them to make their own programs about educating about cancer. And it was really wonderfully successful. And in fact, we looked at our numbers recently about early stage detection of breast cancer, and as I showed you before, it was 33% at the time we started the cancer center. It's now 17%. So this has had an effect, and this study actually showed that this worked. You can actually do this. I mean, you have to find a way to get out in your communities. Obviously, different things, different communities. I don't know if it would work in Alaska, but it did work in a highly densely populated area to use something like the libraries. And this is what I just said. We went from 33 to 17 there, and prostate cancer we went from 45 to 16%. So we did have an effect on our community. So then, just to end, I want to just talk with some of the problems that we have with Medicaid with a cancer care in our community. So first of all the cancer doctors know that multimodality treatment is the way to treat cancer care. That means you need a medical oncologist, you need a surgical oncologist, you may need a radiation oncologist, you need a group of doctors, also psychologists, psychiatry, a whole group of people to help take care of these patients. But Medicaid, you can't do the same 2 visits on the same day and get paid for it. You could do it if you don't want to get paid for it. So that those people are not allowed to get the kind of care that all the rest of us can get in, whatever plan we're in. And for patients who need radiation therapy and chemotherapy in the same day, which is people with colon cancer, people with rectal cancer, I mean, there are a number of types of cancer, that this is the treatment, you can't get paid for both of them on the same day. So hospitals like my hospital have to only get paid for one of them. We lose a lot of money, and we're losing money. I don't know if you all know this, but the hospital system in New York City, the public hospital system in New York City is $1 billion in debt. So, I mean, this is why we're $1 billion in debt. I mean, and we never can get out of this. So they also are doing it that chemotherapy can only be, so Medicaid, you can only reimburse chemotherapy at the acquisition cost. So that means that, you buy it and you can only get what you buy it for, meaning that, giving it, any of the things that go around it, the pharmacy, anything like that, you cannot charge anything for. So then it's a loss. And follow-up care in the outpatient setting is not covered by emergency Medicaid, which all of these other things are covered for, so that's out of pocket. And follow-up tests, such as PET scans, which is state-of-the-art for most cancers, is also not covered by Medicaid. So this is my last slide. One of the big problems in the public hospital system is there's no fundraising. I mean, every other, I've said this is my mantra for 12 years now. Every other cancer center in the United States fundraises. The public hospital cancer center can't fundraise, so that's a big problem. Clinical trials are very hard to do. The NIH doesn't like giving money to the public hospital systems because they don't think that they're coordinated enough, which may or may not be true, but they should be giving money. It's much harder to do research in our public hospital system. We do it, but because there's 108 different languages, you have to translate the consent forms, you have to explain this to people, it takes a longer time, so it's much harder. It's harder to get a trained staff because the salaries are lower. People, don't want to work for lower salaries, and it's harder to get a good trained staff to do the clinical trials, and multiple IRBs, which is and then there is a false perception that minority patients don't want to participate in research. Actually, our patients want to be on research projects, but it's just that they haven't been offered those projects. And then the last thing is that research is not a priority for most of the public hospitals because they want to spend their money, giving care to the patients. I mean, they should be spending the money giving the care to the patients, but there's no incentive. There was no incentive for doing research, no salary incentive, and no protected time. And we've tried to convince the public hospital system that it's important to offer new research for patients, especially with patients with AIDS and patients with cancer. So these are, two diseases that, these things have to be done for. So we've got, a lot of problems, and that's really what I wanted to say.
So I'm going to pick up, when we started 6-7 months ago talking with Vic about this panel, we said, October 1st, Obamacare is really going to be in place, and there may still be some interest in this topic. But it turns out, I guess there's quite a lot of interest in this topic, and of course we all know it's at the it's on the front page every day right now. I sometimes feel I've spoken on panels with Don before, and Don so clearly lays out the situation that we're in and where we need to go to that I often wonder what else is there to say. And then when Peggy talks about the real world, I think you've really heard a lot about what we're really dealing with in healthcare in this country. I come from a little different perspective because I come from what's referred to in the business as the payer side. I run the second largest health insurer in Massachusetts. We are a nonprofit, so like in everything else, here in the Commonwealth of Massachusetts, we do things differently. Between 85% and 90% of all residents of Massachusetts get their health care paid for by nonprofit insurers. So that's very different from most of the country. We also have 99% of children and almost 98% of adults covered by health insurance in Massachusetts. And if only Mitt Romney hadn't forgotten that he did that, we'd be having a very different discussion today. We'd also be having a very different front page every day. I mean, if we hadn't had the massive resistance that has taken place, that Don experienced, Mitt Romney's portrait is in the State House. Every governor of Massachusetts gets to pick a portrait, an artist, and in consultation with the artist, what the portrait looks like. And his portrait, as some of you may know, has on his desk only two things: a picture of his wife Anne and the Massachusetts healthcare law. And indeed, if you look at his governorship, was the thing he accomplished, almost the only thing he accomplished. And so we have real results of it. There are some ways in which the way we approach it here was simpler than you can approach it in a complex country. There also were, as usual, personnel factors. The first thing Mitt did was steal my company's senior vice president of strategy and product development to put it together. And it's not that he could do it all by himself, it's that he knew how you arrange these things and who knew how to do it, and recruited a staff of people from the insurance industry. We're seeing the effects right now of not doing that. All that being said, I really believe that the future of healthcare in this country, all the great goals that Don and Peggy are talking about, really does depend, certainly for our lifetimes, on the success of the Affordable Care Act. If there is, if the opponents who, having failed to derail it by shutting down the entire government, are able to shut it down by saying it is a disaster that people can't sign up for this thing that we were telling you a month ago would be a disaster to sign up for, if they succeed in dissuading people from participating, and I think this is hanging in the balance at the moment. You saw 6 Democratic senators yesterday come forward and ask for a 1-year delay in Obamacare, day before yesterday. And in this political atmosphere, while you can change the staging, the timing of certain elements, if you do a major delay of this, I don't believe you will ever get it cranked up again for a couple of generations. I sometimes like to point people who are just interested in the history of this to a I don't think very widely read, but excellent book called The Heart of Power, which was written by a physician IT expert from Mass General named David Blumenthal and a Brown University history professor named Jim Marone. And he traces how every president, starting with my grandfather, actually, always intended to do health care when the political time was right. And the political time was never right, with the very limited exception of Lyndon Johnson doing Medicare and Medicaid. And that's why when people ask me, why did President Obama expend so much political capital doing health care when we were trying to get the economy going again in this country, and when jobs are so important, I believe he did something heroic. You can argue from the left that it didn't go far enough. And by the way, when you look at the people who say they're opposed to Obamacare, about half of them are people who think it didn't go far enough when you get actually into the internals on the numbers. Or you can argue from the right that everything was fine before. Well, I can make a good case why it's not. It would never be politically or socially practical in this country to go farther as a first step. And I can make a really good case that the way things were before, not just in terms of the number of uninsured, but in terms of until we hit the housing meltdown in 2008, the single highest cause of personal bankruptcy in the United States, healthcare expenses, let alone the outcomes. Compared to other countries, I think I can argue with the left or the right as to why you needed something that approached things the way Barack Obama approaches things. There's a new book by Jonathan Alter about the 2012 election called "The Center Holds," and that's actually Barack Obama. And I think the real one of the tests of this is, are any alternatives proposed by the opponents of the Affordable Care Act? I have not seen any. In fact, you don't even hear. You used to hear repeal and replace. Now you just hear repeal. And so there were a number of questions that we talked about as we were just getting ready for this. I'm going to touch on each of them just a little bit briefly, and then maybe we'll come back to them. But and a lot of them relate to what we've already heard, and I'm sure we'll hear more in a few minutes. But can we deliver health care to everybody and reduce costs? I am firmly in Don's camp that we can do that by focusing on the right things. If we were to do a massive reduction of 1/3 of healthcare costs all at once, yes, there would be losers, although there would actually be winners if it was more coordinated care that brought us to that. But if we were simply to begin to go to a significantly reduced rate of growth, there will be winners all the way along. Now, if you're covering everybody, there are more costs in aggregate. Even then, I think we can reverse that trajectory by doing the right things that we've been hearing about here. And a big part of this, in addition to the sort of coordination of care we've been hearing about, and so on, is changing to a focus on wellness and outcomes instead of just production. Not that production isn't necessary sometimes. I mean, in many times, but changing that focus. Some people ask, if we go down this middle course, is a private-public hybrid insurance system sustainable? We tend to be kind of data-free on this in this country. You can look at Germany or the Scandinavian countries or the Netherlands. They have a public-private hybrid system. We think of that as a single-payer system because everybody is required to participate. It is actually a hybrid system, and every system, as Atul Gawande has pointed out in some of his fantastic articles in The New Yorker, builds on the system they had at the outset. So I believe it is sustainable. Maybe most fundamental question that we have been asked to think about is, can positive changes, can improvements to the Affordable Care Act be affected in this current political climate? And I think that's a very serious question. One of the reasons that we're facing this rollout problem is the inability to make small course corrections, which you always have to do in a major project, for fear that any little adjustment is used to try to kill the whole project. And so my concern about this, about whether we can adjust this to really work well, comes down to two words, and those are Ted Cruz. And then there are so many things that we still need to do, both to improve care in this country, and probably one of the most important is to start compensating primary care physicians at the level that they should occupy in our healthcare system. We've gotten that completely turned on its head. We faced a similar challenge a decade and a half ago with a nursing shortage in this country. We now pay nurses 50 to 100% more than we paid nurses then, and we don't have a nursing shortage anymore. Funny thing, in a capitalist economy, that's how it works. So that's a kind of a quick overview of where I think we are and where I sort of think practically we need to go. And hopefully when we get to some more discussion, I'll get to say some more. I'm going to turn it over to Christine.
Let's see. Sorry. And now for something completely different. I'm really talking about something quite different here. I've been working on the economics of long-term care, which we now call technically long-term services and supports for older adults in particular. Ever since I was a postdoc together with Hal at the Harvard Center for Community Health and Medical Care. And this is the image that's fueled a lot of my work over the years. The boomers are coming. Hey, wait a minute, that's us. So I've started many talks that I've given by admitting to the fact that I personally am at the cutting edge of this age wave that is going to overwhelm the retirement system, just as we overwhelmed the kindergartens and we overwhelmed the prison systems and we overwhelmed everything that we passed through. We are soon going to, according to this, overwhelm the long-term care system. So I've studied the economics of providers and payments in the system, and most recently I've been interested in developing and deploying and paying and respecting the frontline caregivers who are really the heart of this system, the people who give the hands-on care for people with disabilities of all ages, and also how nursing homes can become less institutionalized and more places of good quality where people with disabilities, and we will someday want to live if we actually need that level of care. But today I'd like to talk about a problem to solve. How are we going to pay for the services that our generation will need when we need disability services? The first thing I want to give you is a definition, which I think you probably all realize, but long-term service and supports compensate for functional disability. They're to assist with ordinary things that people can't do, as simple as getting to the bathroom, walking around the room. The instrumental activities of daily living are activities that keep you in the community, that are you able to get a meal on the table. Very, very simple things. They're caused by acute illness, but long-term service and supports are not medical care. So that means that long-term care is not covered by private health insurance because health services don't address functional limitations directly. Long-term care is not covered by public programs. It is not covered by Medicare. That's something that many people in the country don't realize. And we are not sharing our long-term services and supports burdens. And assistance from a person is the key in all of these settings. And people are expensive. Where are these resources going to come from? The main point I want to leave you with today, after I'm going to talk about some other things too, but long-term services and supports is an insurable risk. It's not needed by everyone who ages. 31% of the people turning 65 will not experience a chronic long-term spell of disability over their remaining lifetime. So it's not something that's guaranteed that you're going to need. 20% will have significant disability lasting more than 5 years. So the simulation that this is based on takes a look at how much long-term service and supports people are likely to need. So here's a pie chart that shows that, with 31% with no needs and 20% with 5 years of need, and some folks in between with different lengths of need. Relatives and friends are currently the biggest source. That's the resources that have been depended on for years. 88% of people who live in the community with 2 or more activities of daily living limitations are receiving help from relatives and friends. 35% receive help from spouses, and often this is a wife assisting an older husband, and then she's left on her own without a spouse to help. So this is hugely a women's issue, although of course it goes the other way too. We've seen that happen. Adult children help older adults. 46% receive help currently from a daughter or a son. 29% receive some kind of paid help, and there are not too many people who are not receiving any help at all. But and you should know too that only about 4% of older adults, people over 65, live in institutions or including nursing homes currently. That number has gone down, which is a tribute to changes in our public system and private choices. So many people are predicted to manage their future needs with no spending. They're about 50% in the simulation that I'm basing this work on with no spending. And they either didn't have a need or they relied completely on family and friends, called informal care. But 6%, this is a 2005 simulation, had more than $100,000 in expense. And it's very hard to save enough if you're a middle income person or a lower middle income person to be sure that you're covered for that high end. And there should be an opportunity to share risk. So, and of course, private insurance or social insurance or both could help. So this is a picture of the roulette wheel that we're all spinning according to the spending patterns of the last decade, actually. I think things that may have changed some, and of course the dollar amounts have changed. But this is, spin the ball and see whether you're going to end up in the 50% with no spending or the 6% with more than $100,000 of spending. Options for people are family care, saving and housing assets, long-term care insurance. I put a big question mark there. Probably some of you have that. If you have it, it's protected to some extent. It's not a good time to buy long-term care insurance as the companies are pulling back, and so there is a big question with that. Medicaid is there to cover you if you spend all your assets, and that is meant for the lifetime people who have been poor all their lives, so there's a public policy issue there. And other nations we should be looking at, as Jim said, because they've developed good policies for social insurance approaches for this. Why hasn't public policy addressed this? And the boomers have been coming for a very long time, and our policy really has been stalled. It is actually true that the prime age for long-term services and supports needs is in the 80s. So we are not ready to go into a nursing home tomorrow. I mean, it's not just the cutting edge of the baby boom is going to overwhelm the system tomorrow. But we've had time to think about this for quite a while, and it hasn't been dealt with. The Pepper Commission in 1990 had some recommendations: social insurance for home care, a spending limit of up to no more than $30,000 on long-term services and supports, a kind of catastrophic protection. The Clinton health reform of 1993 included a home care benefit, and we know what happened to all of that. Then in the Affordable Care Act, we had the Community Living Assistance Services and Supports piece that was something that Ted Kennedy had been developing over a long time to provide first dollar coverage for home care at home in particular. That is part of the Affordable Care Act. It's a voluntary public long-term care insurance plan. So in the budget difficulties of 2013 or 2012, at the very last minute, CLASS was repealed. The CLASS Act was determined to be infeasible in 2011, very rightly so. But it was repealed in the fiscal cliff legislation that was debated in those final hours of 2012. And Senator Rockefeller brought in an amendment as a replacement for CLASS to form a commission on long-term care. So it was to be made up of 6 Republican appointees and 9 Democratic appointees. The time frame was 6 months, which eventually ended up being 3, very modest budget. And I had the privilege, I was a fellow at the time on sabbatical from Brandeis, of working with this commission as staff. So we had an intrepid staff, a chief of staff, a junior analyst, 1 fellow, that was me, and some consultants. So my hope was that the policy window on long-term care might be open, at least a crack. And then what happened? We did strive for a consensus, but you can imagine with the appointees that we had what that was like. And I did have people telling me I shouldn't waste my summer on this, but we did vote on recommendations and a report to Congress 6 months after the last commissioner was appointed. So there is a report that you can see online before it's taken down, and I put put the address in there, but you can find it online. So what kind of thing did we come up with? Did the commission come up with? What I wanted to focus on for our discussion here is the financing. There was an individual responsibility vision, as you can imagine, with the makeup of the commission, and this has been our tradition, that people have been responsible for their own long-term care. And that was subsidies and marketed improvements for long-term care insurance, private savings, more stringent Medicaid eligibility, so Medicaid is there for the people who have been poor all their lives and isn't used by people who could have saved, and more active estate recovery for Medicaid, and an education campaign so that people really know about how much long-term care they are likely to need and how they need to prepare for it. There was also a social insurance vision put forward by members of the commission. And one part of that, one idea that was on the table was to expand Medicare to cover long-term care. I personally feel that's a very expensive way to move forward, the way Medicare covers post-acute. It does have post-acute care now, and if we just expanded that to make it long-term care, it would be a very expensive way to do things. But we could have a combination of private and social insurance, and that was another piece of this social insurance vision, that Medicaid remains in place for the poor, and that there is a social catastrophic insurance with a sliding elimination period. So if you need, that you're guaranteed to be covered for a certain amount of long-term care after you have had a qualifying disability for a long time, say 3 years or 5 years, and that could be sliding, so that if you were an upper middle income person, it would be set at 3 years or 5 years, but as a lower income person, perhaps it would be lower, a lower time frame. And if you knew in advance what you needed to fill in, the hole you needed to fill, people could plan for family care and savings and long-term care insurance, and this long-term care insurance market might work for the first time. It hasn't really taken off or worked. So I think this long-term care commission was a kind of pebble in the water rather than anything that can stand up to the silver tsunami that's coming. But it really is something we should be thinking about and concerned about, and it should be something that we're sharing rather than simply individual responsibility. And now, my old friend Hal will take over.
Old friend?
Longtime friend.
Same class.
Senior friend.
Right. So we started with Don at 30,000 feet. I'd say Jim was focusing on top of a hill or a mountain, and Peggy is in the trenches, and Christine is off in long-term care. I owed her that. And I'm going to talk about health care delivery or medical care delivery in the weeds, because I've been focusing on how the delivery system functions can actually change. And I think one of the key parts to it, and I think Don put it very well, we're spending all this money. It's sucking all the increased productivity out of the U.S. economy and putting it into the pockets of providers, insurers, and other people in the delivery system. Every dollar we spend on healthcare is a dollar of income to somebody. And if you think about it in that very simple context, I think it's pretty clear why it's extraordinarily difficult to legislate any change. Because and I'm not even talking about the current congressional bizarreness. And I'm talking about standard U.S. politics, which are different than European politics. In European politics, you have an elected majority, or they cobble together a coalition, and you've got the executive branch, basically, and the members of parliament, or whatever they want to call themselves, and they legislate something. And you don't have committee chairs holding up bills holding up changes. For those of you who vaguely remember the Clinton health plan reform, not Hillary's, but Bill's, it never actually got to a vote. It was killed in committee. And so if you think of it, if you think of that kind of legislative problem, which we built into our Constitution back with the Founding Fathers, there were no mothers at that point, that's what we're living with. But the second part of the problem, and I'd love to hear Don's perspective on the problems that Medicare CMS has had in the rollout of the exchanges, but my guess is that part of it is that there are so many details built into the way the federal government needs to contract with anybody to buy pencils or to buy an insurance exchange that is almost impossible to make anything happen. That is complicated. Easy to make things go wrong. And so the devil is in the details, and in the healthcare system, there are an extraordinarily large number of details. And it's not just details in terms of how one should design a system, but rather exactly which drug should substitute for another one. Or a new procedure gets developed, how do you price that? Well, you have to go to the experts. Well, who are the experts? The AMA or the hospital industry or the payers, they're the ones whose incomes are threatened by whatever change you need to do. So you would have to bring in the experts. The experts have their own biases, whether they admit them or not. Not all of them are evil people. Most of them are not. But they see things through their own perspectives. Neurosurgeons and orthopedic surgeons think the way to deal with a back problem is by doing surgery. Neurologists have a different solution. Chiropractors have yet another. Massage therapists have yet another, and all of them see their patients get better. And so how do you get the answer? So part of what I've been trying to think about is how a delivery system can be changed from the bottom up, not from the top down. Because if we try to do it from the top down, we basically run into these problems of the various interest groups. And we also don't have anybody at the top level thinking about the diversity, thinking about the kinds of issues, the problems that Peggy's facing day to day. Now, you're focusing on African Americans in Queens. Out where I live, we don't have a lot of African Americans in Palo Alto Medical Foundation. We have a lot of Asians, of not just Asians. We actually count them in a whole lot of different categories. We've got so many that we've got well over 100,000 cohort of the 8 major Asian subgroups that we track very carefully, who have different risk factors, respond differently to medications, speak a lot of different language, and we're designing a system that actually has to deal with that because they're our patients. And yet here, hey, Asian is fine. We're worried about African Americans. So the U.S. is so large and complex that to deal with the wide diversity that we have, things need to be done at a local level, not a national level. The instructions need to be made attentive to that. So one of the ways that I've been thinking about it for the last 5 years, doing research within a very large multi-specialty group practice. We're here on the East Coast. West Coast is different. So a large multi-specialty group is over 1,000 physicians. Now, they don't all practice in the same building, 33 odd clinics, lots of different health insurance plans that they deal with. They're all paid internally, essentially on a fee-for-service basis. It's a little crazy-making, and that's what's making it interesting, because to some extent, you can then think about how that might be a model of the craziness that we as a nation might need to be going through. So Don's issue, next to the last slide, I think, or something where you're saying, here's where we are, there's where we want to be, but we have to get over that hump. And part of the problem that PANF and other people are facing is if you want to do things better, and you even have a vision of how you want to get there with the triple aim developed by an IHI, that's great, but how do you do it when most of the folks are still paying you in the old way? Really hard. It's like deciding, oh, okay, I want to switch from this canoe to that canoe, standing. When do you do that? And particularly if they're moving in opposite directions. So that's part of the issue. One of the ways that I actually see some of the changes happening is by something that we haven't mentioned here. We've been talking mostly about legislation, political structures, financing issues. I think one of the key aspects is information. And it's interesting that we're sitting here in a building financed by basically Microsoft profits. It's that ability to access information in a way that one could not have done even 5 years ago. The HITECH Act has really, which encourages, is pressuring medical care providers to build electronic health records. It doesn't just save trees. Okay, that's the electronic filing cabinet version of electronic health record. It doesn't just allow information to move more quickly so that when I see my primary care physician and she, tells me to go pick up my prescription and get some lab work done, she presses the button and the orders are in there. I go to the lab, they know what to do. I go to the pharmacy, I pick up my meds, and I'm done. It means that that information is then stored and somebody can start looking at how care is being delivered within this one large multi-specialty group practice. All the docs consider themselves better than average, of course. They didn't all go to Harvard, but they all consider themselves better than average. And yet there's wide variability in what they're doing. When you have the data in the electronic health record, you can then pull it together and you get them into a room and you say, how do you think you ought to be treating this problem? And everybody knows exactly the right answer. And then you show them the data. And they say, oh, well, your cases are not nearly as sick as mine. That's fine. There's risk adjustment. There are lots of ways that we can dig into doing that. That's the fun part of research. And you can start narrowing it down and narrowing it down, and finally they agree that in fact their cases are no sicker than the other guys, and they're treating them differently, and they're getting not any different results, but they're spending a lot more money. And then you change the ideology, and interestingly enough, this fee-for-service oriented medical care delivery system has bought into the Toyota production system. They call it lean. And the fascinating part is it's not about doing things faster. It's about doing things to increase value to the customer, i.e. the patient in this case. And anything that doesn't provide value to the patient is waste. And why are you generating waste? I mean, that changes the discussion, okay? It generates income to me. No, you're creating waste for your patient. How can we re-engineer what you're doing? How can we have the doctors, for example, standing next to the medical assistants and the nurses and actually talking to each other instead of sending each other emails? And instead of going back to their office and wasting their time going from office to exam room, et cetera, but to figure out a different way to do things. They also get a little exercise by standing, and they're more I don't know about that last part, but I do know about the other parts. And so they are changing the way they're doing things, and they're buying into it. They are actually now reducing, sometimes reducing, but certainly not asking for the price increases that they have built into their contracts with their payers. So they are walking away from money that they could get with the hope that the payers will lower the premiums to potential enrollees. And why are they doing this? They want to steal patients back from Kaiser. Affordable Care Act, it's interesting. It's the clarion call, and from their perspective, hopefully other people will start jumping on the bandwagon. So why am I talking about this? Because I think this is not just something at this one large medical group. Across the street, literally, you can walk to it, is Stanford University Medical Center. probably one of the most patient-unfriendly medical care systems around until recently. It has drunk the Kool-Aid as well. They are changing the way they are focusing on their patients. They are reorienting what they're doing because they want to be survivors in that world. Now, I started off by saying all that medical care expenditure is income to somebody else. Why are these two very large organizations cutting what they're spending? And the answer is they think they will eat somebody else's lunch. And so what I think is going to be happening is a change in healthcare expenditures going down, or at least the rate of growth going down, which is good. Some of that will happen by that leading edge of physicians from the baby booms deciding to retire. So they won't need to draw on that. Hopefully they'll have large enough pensions to pay for their long-term care. But also some changes then, a shift towards increased incomes, relatively speaking, for primary care physicians. We're seeing that. Increased use of nurses and other health professionals to deliver care. Changes in the way that care is organized and patients engaged. And actually, one of the interesting things that PAMF is doing now is it's building a program called Linkages, which is really oriented around a time bank for people to share expertise and capabilities, drive somebody to the grocery store or read with them, and an hour is an hour. It doesn't matter whether you're a university professor emeritus or you have been driving a truck for 30 years. Each hour is worth the same, and the notion is engage those seniors with other people, keep them healthy and at home. So I think there are changes going on, and looking forward to the golden years.
I don't know, I'm thinking that maybe all of Hal's physicians grew up in Garrison Keillor's Lake Wobegon, where all the kids are above average. So now's the time for questions. I really thank the panel for holding to their times, and I was going to say at the outset that, you know, we have these 5 great experts here, but I could have found another 25 in the class if you read through our class report. Okay, questions? First I'll take some from the panel.
I wanted to make a comment.
Sure.
One of the problems in cancer care is that our population is becoming older. The elderly people get more cancer, so we're going to have more cancer in the future. And you were talking about the baby with ALL who we didn't have a cure for. Now we do have a cure for it, but they're expensive. We have a lot of cures for cancer, but they're going to be expensive. So the cancer costs are going up. It's nice to hear about all these other costs going down, but there's no way that that's going down.
And could I just pick up on a couple of things really quickly? One is when you're talking about going from, even in an organized multi-specialty practice, people basically paid fee for service. One thing we've done since going to universal coverage here in Massachusetts, 3 years ago, 17%, our membership is about half HMO and half PPO. PPO tends to be larger, self-funded employers, harder to make change than in the HMO half. But in the HMO half of our, so about 500,000 of our members, 3 years ago, 17% of the providers were being paid on a global payment basis. Today, 82% are being paid. That's how fast you can make change. And that starts to change the incentives. It starts to change how you coordinate and how you work with patients. And then a quick comment on long-term care coverage. The problem that long-term care coverage, from my point of view, has right now is the same problem that we had here in Massachusetts prior to the universal coverage law 6 years ago, which is we already covered pre-existing conditions. We already charged the same premiums for men and women, and all the things that are some of the really important features in the Affordable Care Act. But without it being social insurance. Social insurance is another word for individual mandate.
Mandate,
It's another
yes.
word for saying everybody's in. And whether you do that on an individual enrollment basis or through an employer basis or however, while you could get insurance here, it was unaffordable unless you were so sick that your out-of-pocket costs would be so high that you, if you could, came up with the money. Same problem in long-term care insurance right now. And that's why we don't do long-term care insurance. It's generally done by life insurance companies. But that's why they can't figure out how to price it, because they don't know who's going to be buying it. And indeed, they made some assumptions about who would buy it when they really tried to ramp it up about 4 or 5 years ago. They made wrong assumptions. So now, as you say, they're doing big price increases, and their business is falling. So that is, again, where we need an organized approach to it,
Yeah.
if it's gonna work.
Yeah, any other comments from the panelists for each other, or ready for field them? We'll start back there.
My question is for Jim. I understand from reading the newspaper that you were at the meeting that President Obama had to talk about the Obamacare website. Do you feel that there was anyone in the room who has a clear enough understanding about what needs to be done to fix this, that it can get fixed, and how long do they have any idea how long realistically it's going to take to fix it, regardless of what the legislative deadlines are?
So I'll tell you what I know from my perspective. Don might have another perspective on this. So there were 12 health insurance executives who got an email at 9:30 on Monday night of this week from Valerie Jarrett. It said, can you come to a meeting at the White House on Wednesday at 2? And not so hard for me here in Boston, but we had the head of Kaiser from Oakland and the head of Health Net from Los Angeles, and so on. All of whom showed up for this meeting, Humana and so on. There was, I think, a pretty good consensus in the room on what needs to be done. The question is, can they get organized to do it? And everybody in the room, I'll say here because of course we're off the record and no one's going to report this.
They're recording it.
Yeah,
They're recording it, but only for us.
That everybody, that while it was clear everybody understood where the problems are and what needs to be done, there was a lot of trying to be sure to not personally get blamed for it.
What else is new?
Yeah, right, what else is new, right. There were a number of White House staffers there, but the principal participants in the meeting, besides Valerie, were the Chief of Staff, Dennis McDonough, the Secretary of Health and Human Services, Kathleen Sebelius, and a fellow named Chris Jennings, who was a healthcare policy expert, who was in the Clinton White House, and it was brought back 4 or 5 months ago. Every time we got to a point of what actually needs to be done, as opposed to recognizing the problem, all the other White House folks all turned to Chris and said, he's the point person on this. Zeke Emanuel, Rahm Emanuel's brother, did an op-ed piece on Monday or Tuesday in the Times, in which he basically said, you need to bring in a health insurance czar who has direct access to the president and who has done this before. Well, of course, there's only one place it's been really done before. I had breakfast with that guy this morning. You need, there are some clear management questions in terms of hiring the right people to set the right deadline. And it really sounds like to me that you did not have the people, anybody who was in a position to say, wait a minute, this testing schedule wouldn't work in any setting. I don't care about the politics. Mr. President, you've got to either tell people we're going to be testing this in public or something.
I know less than you do, Jim, but I think here's my take on it. There's a serious technical flaws here, and that's very unfortunate that people are being kept from getting enrolled. There are some threats now to whether the tempo of the way the law is supposed to execute can be maintained. I think it can, but I'm not positive. I just want to look back at the political background. Let's say that everyone was happy right now and we were all getting along together and this happened because of technical glitches. I think we would say, well, that's really too bad. Let's get the intelligence of the country together and fix this. We can fix this. And there'd be no conversation about a basic threat to the idea of healthcare as a human right in our country, or to the kind of really quite important changes this law is introducing. And so this is a politicization of an unfortunate but fixable set of technical problems. That's my view of it.
Part D
Over
wasn't
here.
so smooth either.
Something that's been a mystery to me in the last 2 years, in discussions of provision of health care to all of our population, its cost and its funding. Have there ever been any discussions anywhere about what actually we want to provide? Do we just limit ourselves to pediatric immunizations and appendectomies, or do we cover blepharoplasties and liposuction? Have any of those issues ever been on the table? I've never heard a word about it in any publications.
I guess I should, in the Affordable Care Act, there is a definition of the basic benefit structure. It's got 10 elements to it. It's written into the law. It's in black letter law. It's not regulation. And it answers your question. It says there will be benefits in each of the following 10 categories. And then as that rolled out in regulation, a lot of that decision-making was remanded to the states, so there can be variation among the states in the way they interpret those 10 categories. But I'd say it's a little closer to what you imagine than your question implies. It's still a very difficult set of choices. You know, where do you draw that line, and what's affordable, and how do you get it in under coverage?
And of course, another part of the problem that contributes to the rollout problem is that the idea was that states would decide all of this, and roughly 36 states decided not to do it. And it was not designed to be a one-size-fits-all program for the whole country.
Yep, Stacy?
I'm just trying to, my name is Stacy Petrosky, I'm a psychiatrist, provider, and I practice in Massachusetts and New York City. And to address your specific question about the trust, it's known what is provided. There's an ICD-9 code, and there are codes for procedures. That is what is provided for, and that is what people are compensated for.
Cover all of them in that book that's this thick?
Yeah. They'll
Everyone
cover-
is covered?
And no, it's not, it's sort of done by what you can put in. So the whole thing works is that the provider, we're both providers now, tries to put a label on you, and we'll put in what code you want. So your symptoms will be met by the code. Does that make sense? It's the other way.
John?
I've got a question about how is it, you gave the example of NUCA, this organization in Alaska. Who owned it? How was it, how did they charge? Who compensated? It seemed like a sensible system. But so my question is, how was it organized? Who owned it? Where did they get their money? Who paid for what? So if to find out, can it be transplanted, basically? Can it go elsewhere?
I think there are examples of successful integrated care in many different kinds of payment systems. So I'll answer your question, but I don't want to imply it's the only answer. But the answer there is very clear. I don't know exactly when the law was passed, but I think in the 70s, the Indian Health Service, which used to be a federal function which basically gave care to American Indians and Alaska Natives, that system was changed. And any tribe that wanted to form a native corporation could take over responsibility for health care and other functions, and the federal dollars that would have gone to the federal provider go to the tribe. The tribe becomes the owner of its own care, its own fishery, or its own whatever else is being regulated. That happened, and in the South Central Foundation said, we'll take it. We'll take responsibility for our care. Give us the Indian Health Service money, then we'll buy it back from vendors. And they chose to buy it back from the old Indian Health Service system because they knew them well, but now there's a different set of accountabilities. So the circumstances are, they don't say patient in NUCA. They don't use the term patient so much as they use the term customer owner. Isn't that interesting? So because the community owns it, it's their corporation. They buy the care back. The accountability is to the community, and it's a single payer system. There's one budget for that part of the care. It's rather simple. So it's a very unusual setup, but it provides extraordinary accountability and a lot of opportunity for forward planning because they know what the budget will be. They can decide to use more home health aides or to a recreation program instead of a new CT scanner if they choose.
And just picking up on that, in the weeds in the Affordable Care Act, Medicare, Centers for Medicare and Medicaid Services can establish contracts with what are called accountable care organizations, ACOs. And these are collections of providers, physicians, hospitals, et cetera, who come together, form an entity. If they are able to provide services for their Medicare beneficiaries who don't enroll with them, they just happen to be seeing them, at less than the cost that Medicare is projecting for them, Medicare will share the savings as long as quality is maintained. A really important part of that is that shared savings goes back to the entity. It doesn't just get added onto the fee-for-service payments to all the providers. So the entity can then decide what additional services they want to do, what kind of information system they want to do. They may pay nurses for doing things that don't generate revenue. So it's the ability to capture those funds outside of the standard fee-for-service system, but in that case, the ACOs are built on top of the existing fee-for-service system. It's a really important piece of the act. No one's talking about it, which I think is really the good news, because it's working.
But the bad news is that, for instance, take New York City. They have a Health and Hospitals Corporation, which is the public hospital system in New York. They're not accountable care. So, I mean, it's like, they should be an accountable care organization just from the ground up. They have to make themselves an accountable care organization. To me, that's ridiculous. I mean,
And they don't, you don't have to be in the government program to be an accountable care organization. You have to have the institutional or political will to do it. There are accountable care organizations here that are not federal accountable care organizations. And indeed, you go ahead.
No, but what I'm saying is, I mean, here we have, over 1 million people in New York that, that need to use the public hospital system, and they're not in this group. And it doesn't make any sense to me.
And that should be redesigned that way.
That's right.
There's no question. And it's not even all theory. There's about 70% of people who are on Medicare, like many of us, get their care in a fee-for-service setting. About 30% get their care through health insurance, Medicare Advantage organizations. And not all, but some of those Medicare Advantage organizations, such as ours, have been paying on a global basis since 1994. We get 20% fewer readmissions. We get better outcomes across the board, exactly because we pay for outcomes.
Way in the back, then I'll come down.
Can't hear you.
Drug costs,
Yes.
we haven't really addressed that, and I think that would return, you know, go back to what Peggy's been talking about the high cost of cancer treatment. A lot of that cost is drugs, as I know from experience with friends who had cancer. It just, how do we bring down drug costs and make this system of big pharma accountable to us? I don't know if that's
Who wants to attack Big Pharma?
I do it every day.
Go ahead, Jim.
So I'm sure other people have other takes on that, but absolutely, I mean, the power of Big Pharma's lobbying shows even in the Affordable Care Act, where there is a provision for effectiveness evaluation, as most other countries that have universal coverage have, but there is a prohibition of using the effectiveness the results in determining benefits. And that was lobbied in by Big Pharma. Similarly, under Medicare Part D, the government is forbidden under the law from negotiating prices. This is a matter, again, of political will in this country.
So I'll pick up on that. Even though that political activity precludes Medicare from using that information about benefits, it doesn't preclude you from using those things. So the patient-centered outcome Research Institute.
We aren't talking about that yet, but it's true.
No, but,
your
but,
management of pharmacy's been good all this time,
Yeah.
hasn't it?
Yeah. Tufts
It-
has especially good pharmacy management, I think.
It's true. I mean, and that has spread to the other insurers in Massachusetts, so that for the last 3 years, the overall cost increase in Massachusetts has been below 2% a year, because that has started to spread.
but let me push on a little bit more, because what the Act does do is it created the Patient-Centered Outcome Research Institute, PCORI, which is actually funded by a very, very small tax on insurers and Medicare, and was not hit by sequestration or the federal government shutdown because of that different funding stream. And they are focused on effectiveness from the patient perspective, not just mortality, not just morbidity, but what do patients really care about? It means that I, as a researcher, in developing a grant proposal to PCORI, need to figure out how to include real patients on our study, not in our study, but designing the study. What do people care
So
about?
functionality, side effects.
All that stuff.
That's in the Medicare statute and subsequent regulation, Medicare can't use cost as a determining feature in deciding what to go. If there are two completely equivalent treatments, and one is 1/10 the cost of another, and the evidence is absolutely clear, nonetheless, there's no discretion to use that information in deciding what to pay for or not. For
But-
anything, not just drugs.
Right, but let's say they're both covered, and now patients are able to get really good information that you can get this treatment or that one, and you might live another 2 months, but you will feel really miserable during it. So it's covered. Now, which do you want as a patient? So that, I think, is going to start sending a message to the drug companies that they can make them, they can patent them, they can price them, but the patients aren't going to take them, which will change where their discovery focus goes. So so this is not legislative. This is down in the weeds, changing the demand side rather than the regulatory side.
But often if it's the drug that they can take, they often do want to take it.
But,
That's the problem.
but under the current world, basically they go in there, see their doctor. I mean, I remember the experience with my father. The oncologist came out inoperable, but we've got some promising new drugs. You know, in the room was a psychologist, psychiatrist, a health economist, and a healthcare attorney. And we said, what do you mean very promising? He said, well, probably 6 months instead of 3. And my dad went on hospice care. That's what he wanted. Once the question was asked and answered. But the question would not have been asked otherwise. And so I think people will start making choices to not go with interventions that don't make much difference.
I have to say, in my experience as a surgical oncologist, 80% of the people would not have said that.
That's when they come to you.
You know, they want everything, usually, even if you tell them.
Although there are growing numbers
Yeah.
of people who choose hospice.
Yeah.
Well,
I think, I am an estate planning attorney, and I have the clients, and I have to agree with Peggy. I have clients who sign their living wills saying no heroic measures. When it comes to it, they want to stay alive.
Yeah.
I think it's very different, but I also think it's something that's going to be a generational challenge for us. I think our generation may go and opt for saying no heroic measures, or we want to have the quality of life, and that may be one of the challenges that we can do, which are no cost.
Vic, can I just put a plug in? The organization I used to run, IHI, Ellen Goodman is there now, the Pulitzer Prize-winning columnist, and she started a program called, oh my goodness, the Conversation Project. I don't know if you've all seen it. It's called conversationproject.org. It's amazing, and it's trying to induce much more sophisticated conversation in families and communities so that we get closer to the kind of vision you've got than where we may be
She
starting.
is now speaking around the country about that.
Yes.
Yes.
Kyle, patient.
So, Don, NUCA strikes me as an example of something where if either for good fortune or some other reason, you essentially have a white sheet of paper,
Yeah.
you can design something really good. The problem is that in most cases, we don't. And I don't see anything that's gonna nuke everything to the point that we actually do start with white sheets of paper. And so it just strikes me that, I mean, I'm encouraged by what you're saying, Hal, that there are pockets perhaps of places where you can tweak incentives to move and get over the hump. But I mean, somehow the overall problem, and maybe Massachusetts is another example of going a different way, but somehow it doesn't feel to me like we're going to get there from here to the sort of outcome that a white sheet of paper approach would take you to.
Can I just, I'm not so sure, I see what you're saying, but if you followed the story of NUCA, it wasn't a white sheet of paper. They had just the same kind of hospital-based system. What happened was
a discontinuity that was pretty important.
A change in power structure. So I think essential to that story was a mobilized community that began to feel responsible for care and just said, wait a minute, here's what we want. And I think that's very instructive. And I'm a real optimist here. I think my optimism is on the demand side. I think when people like us and the people you talk to begin to understand what care could look like, and we get our heads straight more at the community level about the kind of approach to burden of suffering that we would really like, I think it's partly a political force, and it's got to counteract the stakeholder forces that Hal was talking about. But I think it's possible, and that's what I saw there. A lesson I've taken away from decades of working on improvement is when the patient and family become powerful, when they're really given power, when they feel that they can take control, things get better, not worse. And I think that whole direction, I think, would be important for the future.
And I would say the change that's going on in Massachusetts is it's not legislated. These are not the ways things are being organized and paid for. That's not legislative change. It's when we got to universal coverage, we went from cost and incentives being a food fight between providers and payers to being a public conversation. And I think if we can get to that, that's where I see getting over the hurdle that you're talking about.
Back here.
I'm also looking at the hurdle, and this is a big picture question. I spent a lot of time in Europe for work, and here I live in New York. I spend a lot of time with Europeans in New York, and they do not, the people I speak with, have no clue as to what the big deal is. Why is this in a, say a so-called civilized, wealthy country that there is no universal health care coverage? And I'm an anthropologist and by training, it's not exactly what I do, but I look at the big picture and I look at the ideological fissures that exist. You said there's a lack of civility. I thought that was a very polite way of saying hatred, real hatred, anger. So it has to come from someplace deeper. And this is something that we really have to understand. People are afraid, terrified of big government, what they call big government. Remember that guy who said, I don't like big government, but keep your hands off my Medicare?
Right. Yes.
It was in the newspaper a long time ago. There's a level of ignorance. And where you have ignorance, you have people who are going to be easily persuaded. Is there something in your knowledge that is being done to educate? Is there an educational component? Frankly, I don't think Obama's done a really cool job on this. I would like to know who is trying to explain to, well, maybe not the Tea Partiers, I'm not sure you can speak with them, but to people who really don't understand and can be swayed easily. Who's doing that?
Don.
I think your sociologic analysis or anthropologic analysis is very close to the heart of the matter. I'll tell you my view. I think that it has become unpopular in this country to talk about moral duty and justice and equity and issues that really underpin getting Peggy's patients what they need and want. My favorite Hubert Humphrey quote that I've been quoting this year was in the corridor, the hallway of the Hubert Humphrey building. He said, the moral test of government is how it treats people in the dawn of life, children, how it treats people in the twilight of life, the aged, and how it treats people in the shadows of life, the sick, the needy, and the disabled. You don't hear that. You listen to the public discourse. Our leaders are in a position right now where they're not I don't know exactly why, but that idea that we owe something to each other and that we have to commit to that social contract, which was, I think, the way they'd say it in Europe, it was not there. I think we need leadership that reasserts that.
And are you testing whether that can be a successful conversation in a political campaign?
I won't answer the question, but I'll tell you, I know it can be a successful conversation, because the answer is when you go out to the communities and you actually talk to people what they care about and their futures and their children, absolutely, they know that. There's somehow the vocabulary's been lost, Jim, and I mean, why is it not there? Or am I wrong?
You know, I think that we shouldn't idealize the past. I mean, there certainly have been tremendous divisions and tremendous hatred at various times in the past. You know, again, you look back to Social Security, which was sort of the same kind of big departure, especially when coupled with unemployment insurance and disability coverage and so on. There was tremendous vilification that went on in that period. I mean, FDR said, I know my enemies hate me and I relish their hatred. Barack Obama doesn't have quite the same combative spirit. There's the famous quote from Ronald Reagan, today is the beginning of the end of American freedom. That was about Medicare. So it's not as if we haven't gotten past this incrementally as we go on. I do believe there's also whether it's in how we fund and organize treating your patients in Queens, or the entire discussion, there is always an underlying division about race in this country.
Xenophobia.
Yeah. And so, I mean, sort of the plurality that is the genius of this country is also what makes it so hard to make progress in this country.
Back there.
Hi, I'm just a spouse, but I'm a clinical social worker, and I work on health reform issues. One of the things I would like to say is that each of us have a responsibility, if we're in favor of this, to go out and educate. I now have my gas station attendant talking to all of his friends about health reform and what it's going to mean to him. I talk to people in the grocery store. I talked to the lady who is going to clean my house next week because I'm having a party and I don't have time to do it myself. You have to talk about it. Talk about it to your children. Talk about it to your neighbors. You have to make it a topic of conversation. And we can do that in this room. And then once you do that, make the 5 simple things. The justice, aren't we for justice? And that, I think that's a very important point to make, because I don't think anybody's going to tell you no. And begin to get people to think about it, but talk about it at church, talk about it at synagogue, talk about it wherever you are, and make it a topic of conversation. Obama can't do that alone. We have to do that.
Just one sort of extension of her comment and question that I have wondered about. So every European country has universal health care. Canada does, several Asian countries do. Not one is the same. And in the United States, where is there universal health care? Massachusetts, Oregon. And it seems these 2 states are pretty successful. They're different. And so my question, when all the political fallout came with Obamacare, before it got voted in and partly destroyed by the dissension against universal health care, I wondered why not somehow empower, make states get their own acts together. Now, I know the Affordable Care Act says all states don't have to be the same, but it seems to me what we're all searching for is a model that works. You can read about universal coverage in England, and everybody says, well, that wouldn't work in America. And you can read about it in Massachusetts and say, well, that won't work in Louisiana. But why not find some way to make universal health care work in every state for that state, whether it needs federal government input or dollars or whatever. So there can be pluralistic systems and then eventually discovery of the best system.
I mean, I think that's
That's where
exactly what we should be doing. I think the Affordable Care Act tries to do that. I think that as we saw with the, the sort of splitting of the difference with respect to Medicaid expansion, this Supreme Court is going to say that federal law can't require that of the states. We are, again, hoisted a bit on our strength being our weakness in some of the ways our country and our Constitution is structured. I really think that one thing that I do think there is a fairly good chance of happening is that in those states that have that are fully implementing the Affordable Care Act, they will be so much better places to live than other states that not overnight, but over time, there will be that kind of model. I think the difference between Kentucky and Texas is going to be huge over the next decade. Kentucky, not what you'd think of as one of the most progressive places in the country, is going forward with implementing the law. In Texas, Rick Perry is massively resisting it, right down to prohibiting state and local officials from providing any guidance on how to enroll, even though now that enrollment is difficult, that's a terrible thing. So I think we're going to get to that in the Winston Churchill way of Americans getting to the right answer after they've tried everything else.
Just as a quick follow-on to Jim's point, Medicaid is voluntary. It wasn't until 1986 that Arizona finally implemented Medicaid. And they finally did, because they said it's a good deal, good enough for us to actually do it and cover the Native Americans in Arizona. That was their resistance. So I think, we'll get there.
Which is a race-type problem.
Oh,
Yeah, that's what- yeah.
yeah.
Right.
But they finally decided to do the right thing.
Yeah, one over here, then we'll come back here.
Question on healthcare costs. In New Hampshire, like a lot of other states, we've done some surveys of the difference in costs for procedures in the different hospitals. It might be X in one and 2X in another. In the manufacturing world, if you're going to apply the Toyota method or Lean or Deming principles, you take those costs and you break them down and see what are the component parts. What we like to talk about as the costs of costs. I don't see that happen. I see a little bit in the Affordable Care Act, like there's some initiatives in this area, but not a real strong effort to find out what are the component parts of these costs. It used to be such a complex problem, we couldn't handle it. But with big data and data analytics, we're beginning to have tools where we can get a better handle on this.
So since we passed the universal coverage law here in Massachusetts 6 years ago, since then we've had 3 more pieces of legislation dealing with cost. The most comprehensive one was passed August of last year. It establishes 2 different state agencies, one the Center for Health Information Analysis. It's gathering that kind of cost data. Then the Health Policy Council, which is the other one, is supposed to take that and translate that into policy recommendations, and even apply it to things like, will hospital consolidations cut costs or simply increase market power? So again, we've got the beginning of a model for it, but you're exactly right about how far we are from doing it.
I understand where you came from. So the financing system we're coming from is a fee-for-service cost-based system, cost plus. So
Cost
whatever
plus
you
system,
whatever
yeah.
you do, you get paid for. So why would there be curiosity? I decided to do something. There'll be a price. It'll be attached. It'll be coded by the owners of the coding systems are the AMA and the people that actually do the procedures. So it was all internal. Now, if we go more toward the global payments where Massachusetts may be heading, the single payer where Vermont may go, The ACOs, where now somebody's responsible for a pot, boy, they get very curious about that. And when they start to do that, it's amazing. Hal mentioned the lean production thinking, where you try to understand just where value is added to the person you're trying to help, and you stop things that don't help. Virginia Mason Medical Center has been at that in Seattle now for nearly 10 years. They've had 1,000 people. Their whole board has gone to Japan for 2 weeks at a time to study lean production, and they're able to take apart costs. It's unbelievable what they're doing. I just read looking forward to a new book coming out about it. Here's a detail. They were interested in the costs of nursing and wasted nurses' time, so they put pedometers on nurses. They found per shift, a nurse was walking 6 miles. Once they did the redesigning and figured out it wasted effort, they've got the nurse walking distance down to 0.6 miles. And can you imagine the improvements?
Now they have to fund a wellness program.
That's for the nurses, for all of these.
It's the skateboard, so I see.
Is there one over here?
Yeah, I wanted to say I think from my point of view, there's been a paucity of expression of less popular points of view, number one, and some of these issues are so complex, and I don't believe some of the negatives have been brought out. For example, the issue of patient empowerment. There's some negatives to that. The moral point of view. There's some negatives to not to a moral point of view, but in thinking that it's a free-for-all. And the issue of unnecessary care is extremely complicated, and it's not just an issue of providers wanting to wanting to grab money. For example, I'm a critical care physician, a retired critical care physician, and the problem of patient demand and physician point of view was at times a horrible one, and that families wanting to keep their relative alive who was essentially dead, if I may say. So these some of the points that have been brought up, in my opinion, are very complicated, and all of the negatives have not been expressed. That's what I wanted to say.
Good spell.
Yeah.
Yeah, I also wanted to mention about in Europe, aren't their taxes a lot higher than what the people in this country are willing to pay? And also, for example, in our county, Alameda County, they're touting in California, they're touting the fact that 1 million more people are going to be covered now with the Affordable Care Act. But who's going to pay for that 1 million people, even getting their, people who had not been insured for whatever reason? But who's going to pay for their yearly physicals and their drugs and their demand for whatever care that they may need? Even the blepharoplasty, it could be because their eyes are falling down and they can't see. It should be covered in that case. It is a medical indication, or even gastric bypass. It could be something that's really needed for the person's health. So it's very complicated. You can't say that should be excluded. And so who's going to pay? That's the question.
But the fact is that you're right about, because they choose to finance, in many European countries, finances through taxes, not all. Taxes are higher, but you have to look at the total expenditure. You have to look at, we are spending somewhere between 50 and 75% more than any European country on healthcare. Or than the Canadians. So you have to look at what we're paying out of our own pockets, what we're paying for premiums, and what we're paying for taxes. Put that all together. Look at what we're paying for these, million people who now have coverage who didn't before. We're paying huge sums for them to go to emergency rooms and to show up sicker than if they were treated sooner. You can't look at you can't just take it in terms of the immediate expense. What expense are you avoiding by the upfront expense? So the elements are all right to question, but you do have to take a comprehensive look. The simple way to look at that is, if it's a solely tax-funded system, the chances that we would move straight to something like that in this country are zip.
Where are you going to find the doctors to take care of these 40 million people?
It's,
Well, it's, there has to be, like Hal said, we have.
You
we have
can't
to invest.
retire.
now, there are a couple of aspects. It's not like we're suddenly having 40 million new immigrants
That's right.
who aren't currently in the United
People
States.
receiving care.
Many of them are getting care through public hospital systems, through public clinics and things of that sort. Where the real shortage is, it's on the primary care side. So one of the things that need to happen is the nurse solution. Increase earnings for primary care doctors. It will become more attractive for those people who are coming out of medical school to go into primary care residency programs. There's also a huge opportunity in terms of advanced practice nursing and physician assistants. And there are ways in which, I mean, interestingly, a redesign, some people are saying, well, the average primary care doctor might have a panel of 1,800 patients. You could redesign that with some nurses, medical assistants, and much more efficient way of managing minor problems on the phone, email, et cetera. That primary care physician might be able to handle a panel of 4,500.
So we are now beginning to see a reduction in wait times for physician appointments in Massachusetts because things are better organized.
Yeah.
We did not, we thought, and it doesn't happen nothing happens overnight, maybe in any human endeavor, but certainly not in healthcare. One expectation that was not met here, there was a belief that as soon as we had universal coverage, we'd have an immediate drop in emergency room care. First 3 years, that didn't happen. A couple of reasons. One is, there were a fair number of people who before waited to go to the emergency room because it was embarrassing to go there and say, I don't have coverage. They now very comfortably went in with their card and went to the emergency room. But moreover, as we look closer at that, we discovered a big part of the problem is a lot of the people who went to emergency rooms went after 5 o'clock in the afternoon. Why? Because they were open. So you have to start shifting and meeting that need for physicians and nurses and physician assistants and so on by having not just urgent care, which is the next step, but even routine care available at 7, 8, 9 o'clock at night. And we've started to see a reduction in wait times.
I mean, physician extenders is probably the solution, and we didn't used to have them before. We have a physician assistants now, and we have nurse practitioners. I mean, it's two groups of people that can take care of a lot of primary care people, and that, I think that's going to be a big part of what we're doing.
And in a state, now, so it's easy to talk about some of this in a state where, I mean, we have more physicians per capita in Massachusetts than anywhere actually in the world, I think. They don't all practice full-time, but we still have lots of them. It is different in a state that is heavily rural like Maine, and with a smaller overall supply of physicians. But there is, you can do, even in that kind of a setting, you can accomplish a lot with fair compensation and reorganization.
But in Boston, if you move to Boston from San Francisco and try to find a primary care physician, it's going to take you at least 6 to 8 months, and you're going to have to call in a lot of favors to do it.
I don't agree with that, actually. If you want as John Kingsdale says, if you want Dr. Famous at Mass General, that's true. If you want a board-certified primary care physician, our one really large multi-specialty group practice is the Atrius or Harvard Vanguard system. I could call up and get an initial visit this week. Well, not this week, it's Friday, next week.
We'll get you a visit.
Good.
More?
Comment on the emphasis in both the discussions about Medicare, and I guess the Affordable Care Act too, but particularly about Medicare, lowering payments to providers, and the discussions of the growing trend of physicians not taking either new Medicare patients or patients who are at an age where they will become Medicare patients. And so the physicians who don't want to take Medicare patients won't take insured patients either of a certain age.
So sometimes that falls into the moral hazard category. My favorite term that I learned from economists and public policy people. And sometimes you have to deal with things by regulation. Sometimes you have to say, you want to participate in Medicare at all? You have to take all comers. Or you want a license? You have to take all comers.
Increased number of pediatricians.
Yeah.
Data are not all that disturbing. Most doctors are staying in the system in Medicare, and in fact, as of 2 years ago, I think it hit the highest all-time participation. There's a lot of alarmism about it, but so far people seem to understand it comes with the territory. The payment cuts to physicians are not due to the Affordable Care Act. There's this anomaly that it's a sustainable growth rate. It's too complicated for 358, but basically Congress passed a law that they then didn't enforce, and because they didn't enforce it, there's now a gap, a statutory gap between what physicians are paid and what they're supposed to be paid under the law, and that's a 31% gap right now. It's absolutely impossible, so they're going to have to figure out how to close that gap.
It actually was enacted to try to do away with Medicare.
Yeah, is that right?
Yes.
And they never implemented it. So, but there's a lot of fixing to do. But I think on the whole, you're going to see encouragement to primary care and now more accountability for quality. The idea in this law is that hospitals, for example, that have very high readmission rates will get paid less compared to ones that are able to keep their readmission rates down by having more continuity of care. Hospitals that have high complication rates actually are penalized in the law compared to ones that don't, which is a problem with the safety net systems, where that has to be fixed.
Yeah.
But I think on the whole, the payment system is going to get fairer and more understandable.
And one word that hasn't been used, at least much yet here, that is really important for all of this, is transparency.
Yes.
If people know where you can get better care, and the classic example here is all the celebrities go to Mass General to have their hip replacements. In fact, if you ask people around the country, in fact, our governor and our Secretary of State went there. People in healthcare would go to New England Baptist, which has a 0 surgical infection rate, which is 50% cheaper, and so on. But even these celebrities don't know that that's the right choice.
Well, celebrities don't.
They
never know anything, yeah.
Celebrities don't know anything.
Yeah, that's right.
Jim, there's Tufts Health Plan has a product called a SCO. It's only for dual eligible people. So they're the poorest and generally the sickest of our population, but it's a small cohort of people. But the nice thing about a SCO is that it coordinates between skilled and unskilled care. So, and that's a critical link that's missed in prevention and regular care. Do you think that model is applicable or scalable to the general public?
So let me translate the acronym. So SCO stands for Senior Care Options, and it's for people who have both Medicare and Medicaid. This year we only have it in 1 county. Next year we'll have it in 10 counties. We think it is scalable. The principle of it, I mean, this is for a population that also has Medicaid, so it's a poor population. But the principle of it is the same as a coordinated care Medicare Advantage product, but it has the resources because of the Medicaid to go farther and include long-term care. I actually think we may develop out of that enough data to actually ultimately make long-term care coverage convincing to actuaries. That's the problem with it right now. We have an under 65 program that is just beginning January 1, and it's a national demonstration that's going on in a number of places called Under 65 Duals. Again, people with Medicare and Medicaid, which in under 65, that means disabled people. Those are the people who have Medicare or under 65. Most insurers in Massachusetts, well, first of all, most insurers that are principally the big commercial insurers, Blue Cross, Harvard Pilgrim, and us, we're the only one that has both a Medicare product and a Medicaid product. So we're willing to take the financial risk after a lot of hard-fought negotiation with CMS, after he'd left there, to try to get some risk sharing with the government that made sense, and indeed they were willing to negotiate that. There's a lot of that kind of demonstration that is better coordination and possibly, for those who need it, more comprehensive services that's going on. We'll see how it works. We decided that we, with 1 million members overall, we could put our money where our mouth was and try it.
Was there one right here?
Now, I had wondered whether you had any suggestions for solution on rural health care. I think in the New York Times, there's an article saying that the premiums are not lower because there isn't, under the Affordable Care Act, because there isn't enough competition. And it seems to me this is kind of self-fulfilling. We're going to have red states and blue states, as we were saying before. And I think we're in another civil war in this country between rural and urban.
You even find very little Medicare Advantage in more rural areas for many of the same reasons. One little talked about so far facet of the Affordable Care Act is that the federal government is required to offer a nonprofit alternative at the outset in 30 states, but ultimately in all states. They didn't announce the beginning of that program until about 2 weeks before open enrollment began. And indeed, the problem I had with the New York Times article highlighted a real problem. It didn't take into account this nonprofit alternative that's going to be available, mostly because they got so far behind on it in the federal government that it doesn't appear yet on the exchanges, but it will by the first of the year. So again, the beginning of something to try to deal with that, probably not perfect.
Yeah, Larry, you have.
Yeah, and as I say it, I think the economic effectiveness of the Affordable Care Act will largely depend on enrollment of young people. And I don't know exactly what their options might be, but it would seem to me that, and perhaps you can tell me, but the ideal would be offering younger people very high deductible insurance, very high copay insurance, but educating them fully on the value of having that insurance. And the Democrats are not doing that, where the Republicans are out proselytizing, affirmatively telling young people that it's a bad investment.
Well, I agree with the statement that the education process has not been done well. There is a catastrophic coverage for young people in the law, which will be considerably less expensive. And moreover, there is coverage for pre-existing conditions and so on, because there are young people who have, infection-induced asthma when exercising is a pre-existing condition that gets you excluded in some places, including by Kaiser in California, up until now. And that's going to be done as of January 1st. So that does exist. It's not being sufficiently promoted yet.
One of the favorable stories here is what some of the successes in some of the state exchanges. Kentucky, California, they're doing very well. California was very worried. That's 1/8 of the country, massive exchange. It turns out the way that was set up, they were able to create attractive packages, and the actual premium in the exchanges is about half of what was estimated by the Congressional Budget Office. So they're clearly showing that this problem can be solved. It can be made attractive to the right mix of enrollees.
I'll take one more. Well, actually, I wanted to engage everybody, and I think we've done a pretty good job, and panels have been great maintaining their time, but we'll take another at least. Yep.
Does medical insurance take into account the global nature of medical care? Like people who go to, say, India to get medical care, but lower cost than they would get here.
Send our patients over there.
Right. So, typically, health insurance in this country, as in other countries, does not cover care that is, the somewhat. Well, some people think it's attractive, some people think it's a pejorative term for it, that's medical tourism. And so typically, the national health in the UK doesn't cover you to go to the United States, and health insurance in this country, whether private or governmental, doesn't cover you to go to Costa Rica or India. Whether that becomes more prevalent in the medium term, it's not clear to me. There are some employers that do actually, because insurers will do in the commercial market. Insurers will do what employers want as long as they'll pay for it. And there are some employers that do that, but it's on a very limited basis.
Are we done? Well, I really want to thank all of our panelists and all of you for your good questions. It's been great.